بسم الله الرحمن الرحيم. أعزائنا طلاب المرحلة الرابعة في كلية الطب جامعة ميسان، السلام عليكم ورحمة الله وبركاته. هذه محاضرة فيديوية في الجراحة عن الباراثايرويد glands and adrenal glands، وهي استكمالا لمحاضرات الاندوكراين سيرجري اللي بدأناها بالثايرويد gland. About parathyroid glands, we have 4 parathyroid glands, 2 superior and 2 inferior, also 2 on the right side and 2 on the left side. We can see here the cross section in the neck. You can see the thyroid gland, cross section of thyroid gland, and this is the carotid sheath. This is the carotid sheath, and this trachea, esophagus, recurrent laryngeal nerve, and here we can see one of the parathyroid gland here and one parathyroid gland here. It is directly related to the thyroid gland. And parathyroid gland are responsible for secretion of parathormone, and their secretion is not dependent on the pituitary gland. They are pinkish in color in children microscopically and yellow to brown in color in adults. Their size about 0.5 centimeter in diameter. Their blood supply from inferior thyroid artery, 95% of patients, through a leash of blood vessels. Histology of parathyroid gland. There are principal cells, also called chief cells, are responsible for secretion of parathormone. Also, you may find water clear cells. It is usually found in hyperplastic and neoplastic glands. These cells are rich in glycogen. Also, near puberty, we may find oxophil cells and abundant fat cells. About parathormone, it is peptide hormone containing 84 amino acids. It is secreted by parathyroid gland in response to low serum calcium. The congenital anomalies of parathyroid gland is, we called it DiGeorge syndrome. It is congenital absence of the parathyroid gland and thymus, result in neonatal hypoparathyroidism and thymus-dependent lymphoid, absence of thymus-dependent lymphoid system. About disorders of parathyroid glands, first group is what we call it hyperparathyroidism. Types of hyperparathyroidism. First type is primary hyperparathyroidism, in which the etiology may be due to adenoma in 92% of the cases, usually in middle-aged female, and usually affect one gland. Also, another etiology of primary hyperparathyroidism is multiple adenomatosis, more than one adenoma, in 4% of cases. Also, another third cause is hyperplasia. Hyperplasia in 3% of cases affect 4 glands. Carcinoma very rare, less than 1%, and in primary hyperparathyroidism there is elevation of parathormone and calcium level. Second type of hyperparathyroidism is secondary hyperparathyroidism. Here the hyperparathyroidism is due to compensatory hyperplasia of parathyroid gland due to prolonged hypocalcemia that occur after many causes like chronic renal failure or malabsorption syndrome. Result in hypocalcemia, and in response to this hypocalcemia, there will be compensatory hyperplasia of parathyroid hormone. Third type is tertiary hyperparathyroidism. Here, after prolonged secondary hyperparathyroidism, this is complication of secondary hyperparathyroidism. After prolonged secondary hyperparathyroidism, the parathyroid gland will end in autonomous state, has autonomous function. It will secrete parathormone without control, without feedback control, autonomous secretion of parathormone. Here, the parathormone and calcium level both are elevated. While in secondary hyperparathyroidism, there is what we call normocalcemic hyperparathyroidism. The calcium is not elevated, but parathormone is elevated. Also, the fourth type is what we call paramalignant syndrome. It is ectopic parathormone by other tumors like small cell bronchial carcinoma. This is the most common tumor that secretes the parathormone, ectopic secretion, responsible ectopic secretion. Let us talk about a clinical picture of hyperparathyroidism. It is summarized into bone, stone, psychic moon, and abdominal ground. Bone, stone, psychic moon, abdominal ground. Commonest presentation is asymptomatic hypercalcemia. Asymptomatic hypercalcemia. The earliest complaints are muscle weakness, anorexia, nausea, constipation, polyuria, and polydipsia. Let us start with the bone. There may be bone pain, osteitis, fibrosis, cystic care, which result in multiple bone cysts. Also, there may be pathological fractures. Stone, those patients with hyperparathyroidism, usually 30 to 80% of them, there will be recurrent renal stones. And in 5 to 10% of them, there may be nephrocarcinosis, which is calcification of renal parenchyma. So, in any patient with multiple or recurrent renal stone and nephrocarcinosis, you have to look for and you have to investigate for the hyperparathyroidism. Another type of manifestation or of symptoms of hyperparathyroidism is abdominal groan, which is regarding the GIT. There may be anorexia, nausea, vomiting, peptic ulceration, acute pancreatitis. While about psychic moon, there may be, it is common in female. It results in apathic female with lack of concentration and may have depression. Keep in your mind that in patients under 60 years of age, urological presentation are common, while above 60 years of age, neuromuscular and psychiatric manifestation dominate. What are the differential diagnoses of hypercalcemia? On the top of the list is hyperparathyroidism or secondary tumor in bone or cancer with endocrine secretion or multiple myeloma, vitamin D intoxication, thyrotoxicosis, some drugs like thiazide, diuretics, lithium. What are the required investigations? We need a group of investigation to confirm hyperparathyroidism and a group of investigation to localize the cause of hyperparathyroidism. For confirmation of hyperparathyroidism, we need to do serum calcium. Usually there is increased serum calcium except in secondary hyperparathyroidism, which we called it normocalcemic hyperparathyroidism. There is also decrease in serum phosphorus and decrease in serum parathormone. Also X-ray, we have to do X-ray in these cases, and we may find there are multiple bone cysts and resorption of terminal bone of phalanx. About localization of parathyroid gland, disease parathyroid gland, we have to do CT scan, thallium 201, technetium 99 subtraction scan, and better than this scan for localization now, recently we called it Cyst-A.م.D scanning. Cyst-A.m.D scanning, this is most accurate than thallium technetium subtraction scan for localization of parathyroid disease, parathyroid gland. Treatment of hyperparathyroidism. If it is primary hyperparathyroidism, needs surgical treatment. When there is parathyroid adenoma, the adenoma is excised. The disease gland is excised with its adenoma. And when there is parathyroid hyperplasia, we should resect the 4 glands, and we have to implant one of the glands in the sternum muscle or in the deltoid or in the forearm muscle. Why we do this? If in the future we need to re-explore it, it is really can be done. The procedure is easy. If there is recurrent